it was a very interesting organization, but we didn't know too much about which kind of patient they had, and how many patients, which is the age. So we can move now to the last presentation of the conference, that it will be given by Reinis Balmaks. Reinis Balmaks is coming from Riga, Stradins University. Please.
Hello, everyone. Thank you for inviting me to this conference. I will tell you about COVID-19 in the Pediatric Emergency Department in Riga, Latvia. So first of all, COVID epidemic in Latvia has been quite mild so far. Here you can see the cumulative number of cases. The first case we got was on the 1st of March, and up to now we have only about 800 cases and 13 deaths. If you look at the age structure, we've had only 53 children, less than 19 years old, and it's total 6% of all the patients or COVID positive people in Latvia are children. This is a map of Children's Hospital in Riga. We have only one children's hospital in the whole country of Latvia. And it's an old hospital. It was built in 1899, and it's built at the time's fashion. So it consists of several barracks and then a couple of newer buildings. So different wards in our hospital are in different parts of the park where the hospital is located. And the emergency department is in this 1970s tower. ICU is a separate building built in 2000s, and infectious disease ward is in a barrack built late 19th century, 18th century, sorry, 20th century. Yeah, well, 1899, that's what I meant. So that's how we traditionally, since ever the hospital has been built, have been organizing patient flow. So infectious patients are, when they need intra-hospital transport, they're transferred outside. So to answer the first question, so as I said, there's only one specialized pediatric emergency department in our country. It's a rather busy unit with 70,000 visits per year. And when the patients now come to our emergency department, they need to ring a doorbell, and they are triaged through an intercom. And there's three paths of the patients. So infected patients or suspected cases go directly to a negative pressure room that has entrance from outside. Patients with fever and some other respiratory symptoms are treated separately, and then we have sort of what we call clean patients with trauma and other non-infectious problems. So they have a different flow. In our hospital, only one parent at the moment can be with their children. Everyone in our hospital needs to wear face mask. It's patients, parents, and staff. So this is how it happens. So here's a mother that rings the doorbell. She gets triaged through intercom, and only if they're not suspected to have COVID, they get entrance in emergency department. Other patients, if they were suspicious for COVID, they would go to a different door. This is photos from our simulation, and this is what the negative pressure isolation room looks like. So it has separate entrance from outside. The staff goes through the inside, and if the patient needs to be transported intra-hospitally, that happens through outside. So we defined traditionally coronavirus based on clinical symptoms and travel on contact history, and COVID tests are done to anyone with symptoms or typical history, and now we screen everyone who is hospitalized in our hospital. So how do you manage the suspect patient in the emergency department? We isolate them in negative pressure room. So if they are stable, the history is taken over the phone before meeting the patient. During the physical examination and when the nasal swab or oral pharyngeal swab is taken, then everyone wears personal protective equipment. So this isolation room has a separate X-ray and ultrasound equipment, so we wouldn't have to bring in shared equipment. And so far we've been quite lucky because the patients needed only supportive treatment and haven't been seriously ill. So we defined a coronavirus infected patient, but with a positive swab. That's an RNA test. It's a send-out test. We send it to an infectious disease center. The turnaround time is about 24. Well, it's about 4 or 5 hours. Sometimes it takes even up to 24 hours. I think we covered this one. So we test parents only or caregivers only if they have respiratory symptoms. Otherwise, we advise them to see the adult doctors. And the patients we've had so far, it's only 6 patients. One 10-month-old with a fever, 7-year-old with a fever and new onset seizures. That was news for me during this conference. It's a common theme in other countries. I hadn't been reading about this. We had a small infant with a fever and poor feeding and lethargy. And we admitted also the parent, mother. In this case, she had some mild respiratory distress and required oxygen. And that is our hospital's plan to admit mothers of newborns as well to Children's Hospital. We had a 13-year-old asymptomatic and a 16-year-old with frontal sinusitis. No one has needed intensive care unit, and there are no deaths among children in our country. So that's all from Latvia. Thank you.
Thank you very much. So, do we have any question for Reinis? I mean, I see that your experience is just with a few patients. You don't have too many patients that are infected with the virus, fortunately.
Yes, I must disclose that I work in intensive care unit, just like Monica mentioned, and we haven't seen COVID intensive care doctors. It's only infectious disease and emergency departments.
Okay. There is a question from Francesco.
Io c'ho una domanda. I have a question. Franzoni.
Yes, go ahead.
Okay, can I go? Maybe the question was taken in account for you, but I was obliged to go out, and I asked it again eventually. The seizure, do you put a connection between seizure and or is a febrile seizure or afebrile seizure, I mean, and you connect the seizure with the virus or not?
So thus far we were unsure, but today during this conference I learned that many other centers have seen patients like this. Some of the speakers referenced studies that I haven't read. That's a new information for me. So, but it seems like it's a recurring theme among COVID patients. At least it seems to me today.
Okay, thank you.
Okay, so if we don't have other question, we can close the conference. I would like to thank very much Riccardo Lubrano that have the idea to organize this nice international conference, and to all the speakers and to all the attendees. We reach almost a number of 200 people that were listening to the conference. What we can say about the conference, that most of the organization of the hospital in a way is very similar, with 2 flows, one for the COVID positive patient, one for the non-COVID patients, and of course it depends on the facility where you work. The criteria for the diagnosis are very similar according to the different countries. This is the idea that I had after this conference. What amazing me a lot is the number of patients that is very different from pediatric patient, is very different from countries to countries, and not only the number of patients, but also the severity of the disease. We have seen our friends from Washington, D.C., that they were reporting a big number of patients, also with patient intensive care unit. And what amazing me that the situation in the countries, at least in the country with the higher incidence of COVID-19 patients, is very similar from the north to the south. In Italy, we have the highest number of patients in the north. In the United States, also, if the first patient were diagnosed in California, they had the higher number of patients in the north east of the country. So I don't understand this. That depends on the climates or in the crowding of the people, but really there is a difference from north to south in the countries. I don't know what you think, Riccardo.
Yes,